We are starting with slide 49 from the chapter 22 part A set of slides. Had to think, sorry. We are starting with the trachea. We're still in the, we're actually in the lower respiratory tract because the lower respiratory tract starts with the larynx. So the trachea is the windpipe. And I know one thing that you need to know about the trachea is that in order to prevent the collapse of the trachea, it contains 16 to 20 C-shaped cartilage rings. So they're C-shaped because there's a little opening that allows for when the esophagus expands, when you swallow food, that's kind of behind or posterior to the trachea. And so that those cartilage rings are not completely closed into an O shape to allow for you to swallow food. Now, let's move on. I do also want you to know the trachealis muscle contracts when you cough to help you expel mucus. And this shows you the trachea, the C-shaped cartilage, and then behind it, the esophagus where food is going to go. Okay, and notice the cilia that lines the cells that line the lumen of the trachea, that the cilia that lines basically the trachea and the bronchi, that helps to sweep mucus up and out of your respiratory tract. So, and you can see here, again, this is pseudostratified ciliated columnar epithelial tissue. Maybe you remember from Bio 168. And that is the lining of your trachea and respiratory passageways. Here is an electron micrograph which is the cilia blown up about 2,500 times. And our clinical note contains information about these cilia because smoking cigarettes ultimately destroys the cilia. It inhibits the cilia and ultimately, it paralyzes the cilia. So without ciliary activity, coughing is the only way to prevent mucus from accumulating in the lungs. That is where smokers get the smoker's cough. So the good news is when a person stops smoking cigarettes, the ciliary function usually recovers within a few weeks, and the smoker's cough will subside once that function is restored. Now, the lung cancer risk is still there, of course, but it's going to go down. You know, the less you smoke, the less statistically your risk is. All right, then the next clinical note is about an obstruction in your windpipe, your trachea. Tracheal obstruction is life-threatening. Many people have suffocated after choking on a piece of food. The way to remove that food is the Heimlich maneuver. The maneuver is simple to learn and easy to do, but it's best learned by demonstration, since when you do it incorrectly, you can crack someone's ribs. But that is the way to expel food when there's a tracheal obstruction. All right, the trachea branches into two main primary bronchi. There's the left that branches to the left lung, and the right primary bronchus that branches to the right lung. And then each primary bronchus branches into secondary bronchi. And there's one for each lobe of the lung. So there'll be 3 secondary bronchi for the right lung and 2 for the left lung. And after the secondary bronchi, those branch into segmental or tertiary bronchi, which then branch into bronchioles. And the bronchioles branch into, eventually, clusters of air sacs, and each air sac is called an alveolus. So plural is alveoli. There's about 300 million alveoli that make up most of the lung's volume. So about 150 million per lung on average. Then the alveoli are the sites of actual gas exchange, oxygen from the lungs into the blood, and then carbon dioxide from the blood into the lungs. And this is what the clusters of alveoli look like. First you have the terminal bronchiole that branches into respiratory bronchioles, and then those respiratory bronchioles branch into alveolar sacs, which look kind of like a cluster of grapes. And you can see that each alveolus, one of these sacs, is surrounded by its own capillaries. Okay, now you do need to know what the respiratory membrane is. The respiratory membrane is the membrane across which the gases are exchanged. So it is the blood-air barrier that consists of the walls of the alveoli and the walls of the capillaries, along with, since they are composed of epithelial tissue, they each have a basement membrane, so their basement membranes are fused. The respiratory membrane is very thin, and that is so that the gases can be exchanged across that membrane by simple diffusion. Oxygen is going to diffuse from its high concentration in the alveolus into its lower concentration in the capillaries, and then carbon dioxide is going to diffuse in the opposite direction from the capillaries into the alveoli, where we will then breathe them out. Now, the walls of each alveolus consist of certain types of cells. There is a single layer of squamous epithelial tissue. We call it simple squamous. And these cells are called type 1 alveolar cells. And then there are scattered cuboidal cells that secrete surfactant, and they're called type 2 alveolar cells. And then there are macrophages, alveolar macrophages, that migrate through and keep the alveolar surfaces sterile. There are about 2 million dead macrophages per hour carried by the cilia to the throat and swallowed. So they help to keep our lungs free from infection. And here we can see the type 1 cells. Each one of these that look kind of like a fried egg are our simple squamous cells. And then the type 2 cells are the surfactant cells, and then the macrophages. Okay. Now, for the lungs, make sure that you know that the left lung, the separation between the two lobes is called the oblique fissure. The left lung is smaller than the right because of the heart being on the left side. And then there is a cardiac notch, which I'll show you, which is just a concave notch for the heart to fit into. The right lung is separated into 3 lobes, and the superior and middle lobes are separated by the horizontal fissure, and the middle and inferior lobes are separated by the oblique fissure. So you have here in the right lung, the horizontal fissure and the oblique fissure, and in the left lung you have just the oblique fissure, and then you see in the left lung there's this little concave depression to allow the heart to fit into that space. That is called the cardiac notch. And this is just a transverse section showing the right and left lungs. Okay, the membrane that surrounds the lungs, the serous membrane that surrounds the lungs, is called the pleura. It is a double-layered membrane, of course, because all 3 of the serous membranes are. The outer layer that lines the thoracic wall is the parietal pleura, and then the visceral pleura actually contacts the surface of the lungs. In between the visceral and parietal pleura is pleural fluid, and which provides lubrication and surface tension. And here is that image again. You can see the parietal pleura lines the thoracic cavity. It's on the outside. And the visceral lines the lungs, the actual surface of the lungs. And in between would be the pleural fluid, the pleural cavity, which holds the pleural fluid. So a clinical note is on the condition called pleurisy. Pleurisy is defined as inflammation of the pleura. Often it comes from pneumonia. The inflamed pleura become rough, and that results in friction, and it's painful breathing. Every time you breathe, it's like a stabbing pain. The pleura may produce excessive amounts of fluid, and that may exert pressure on the lungs and hinder breathing. So, other fluids that may accumulate in the pleural cavity is blood, if you have damage to blood vessels in that area, and blood filtrate, which is a watery fluid that oozes from the lung capillaries when you have left-sided heart failure. So, what do we call that? Happens when people are dying. I can't think of the name of it. I'll think of it later. I don't want to stop the recording. But pleural effusion is the fluid accumulation in the pleural cavity. So that's just the term for the fluid accumulation in the pleural cavity for whatever reason. The person has gone into cardiac. Gosh, I just can't think of it. Okay, let's move on. We're not at our 15 minutes yet. So let's move on into section B, 22B. Where is it? In the downloads, 22B. Here we go. All right, section 22B starts with some notes on respiratory physiology or function of the respiratory system. Now, when we breathe in or inhale, that's called inspiration, and when we breathe out, it's called expiration. Exhaling is expiration. Ventilation just refers to breathing, so we have the two phases, inspiration and expiration. In order to understand why air moves into the lungs and out of the lungs, we have to be able to understand the relationship between volume and pressure. So you need to know that atmospheric pressure, the pressure of the air around us, is 760 millimeters of mercury at sea level. And so that we have to compare that to the pressure inside the lungs, to different pressures inside the lungs. So some of those pressures that you need to know and understand are the intrapulmonary pressure. Intrapulmonary pressure is the pressure inside the alveoli, and that fluctuates with breathing. And then there's intrapleural pressure, which is the pressure in the pleural cavity. And again, that fluctuates with breathing, but what you need to know about intrapleural pressure is that it's always a negative pressure. It's always 4 millimeters of mercury less than the intrapulmonary pressure. So that negative pressure keeps the lungs from collapsing. If fluid accumulates and positive pressure develops, then the lungs do collapse. So that pressure, that intrapleural pressure, always has to be negative so that the lungs will not collapse. There are forces influencing the intrapleural pressure that overall end up becoming, making it a negative pressure. But the two inward forces that promote lung collapse are, number one, the lung's natural tendency to recoil. Once you inhale and the lungs stretch, they always tend to recoil due to their elastic tissue. And number two is the surface tension in the alveoli due to surfactant. Due to just the fact that the alveoli are composed of fluid, so that causes a surface tension. Surfactant helps to fight that. So the outward force is the elasticity of the chest wall, plus which pulls the thorax outward. So the negative pressure is affected by these forces, but it is maintained by the adhesive force between the parietal and visceral pleura. So the intrapleural pressure is overall negative, and that keeps our lungs from collapsing. That's what you need to know. The transpulmonary pressure is the difference between the intrapleural pressure and the intrapulmonary pressure and the intrapleural pressure. So that is the pressure that keeps the lung spaces open and keeps them from collapsing. The greater that transpulmonary pressure, the larger the lungs will be. If the lungs are going to collapse if the two pressures are equal, or if the intrapulmonary pressure is equal to atmospheric or higher than atmospheric. So you must have negative intrapleural pressure to keep the lungs inflated. I've said that over and over. That's the main thing. Make sure you know the name for the pressure in the alveoli is intrapulmonary pressure, and the intrapleural pressure is the pressure that must be negative in order to keep the lungs from collapsing. And the transpulmonary pressure is just the difference between the intrapleural pressure and the intrapulmonary pressure, okay? Intrapleural pressure is always negative. So when you say 0, take away -4, that equals +4. If you remember, you have to, subtracting a negative means you add the positive. So that's a little math review. So anyway, but the most important thing is to know that this pressure in here, this intrapleural pressure, which is the pressure inside of the pleural cavity between the visceral and the parietal pleura, must be negative in order for the lungs not to collapse. A pneumothorax is a collapsed lung, and that's when air goes in, when air enters the pleural cavity, and that is going to lead to a collapsed lung, and that can happen due to, in this case, you have someone got stabbed, but it can happen in a car accident as well. Atelectasis is lung collapse due to plugged bronchioles, which can cause collapse of the alveoli, or due to a pneumothorax, which is air in the pleural cavity. Now, back to breathing, ventilation, that's inspiration and expiration. Breathing relies on the relationship between pressure and volume, which is called Boyle's law. And that relationship means that pressure and volume are inversely related. So the greater the volume of the lungs, the lower the pressure. And the lower the volume, the greater the pressure. So when you inhale, first of all, let's talk about the muscles involved in inhaling, because the muscles are going to contract in order to give you a larger volume in your chest cavity. The muscles involved are going to be the diaphragm, which is going to contract and move down or move inferiorly and flatten out. And the external intercostal muscles are going to cause your ribs to expand. And together, that is going to increase the volume in the thoracic cavity. And when the volume is increased, the pressure decreases. And that is going to cause air to move from outside where the pressure is higher to inside where the pressure is lower. So this shows you when you, well, this is all the sequence of events. Your muscles contract, your inspiratory muscles contract, your diaphragm flattens out, and your rib cage expands, and that increases the volume in your thoracic cavity, and that decreases the pressure, and that is going to lead to air moving into the lungs. And the opposite happens when you exhale, when expiration, is that all of those muscles that contracted now relax, and that causes the diaphragm to move up and kind of form a dome shape, and that's going to decrease the volume, and the ribs are going to, those muscles are going to relax, so the ribs are going to relax and move closer together. So the volume in the chest cavity is lower, which increases the pressure, which causes air to move out. So this entire figure explains the physics behind inhaling and exhaling. So inspiration, again, as the volume increases in the thoracic cavity, that causes the intrapulmonary pressure, the pressure inside the lungs, to drop, and air will flow into the lungs toward the lower pressure. Now, sometimes we breathe deeper, so in forced inspirations or deep inhaling, this can happen during vigorous exercise or in people with COPD. The accessory muscles are also activated, so you need to know the accessory muscles that are involved in deep breathing, deep inhaling, or forced inhaling, and that will be the scalenes, the sternocleidomastoid in your neck, and the pectoralis minor in your chest.